Hi everyone, hope you're all doing good. This is Dr. Prithika here, and through this e-learning module at the 51st IPS conference, I'm going to talk with you all regarding resin bonded bridges. So let's see the learning objectives of today's module. So at the end of the module, I want you all to define and understand the concept of what resin bonded bridges are about. We also should be able to understand where to use and where not to use these resin bonded bridges. The advantages and disadvantages have to be evaluated. And also, I want you all to know and classify the different types of resin bonded bridges. And finally, have a clear idea about the step-by-step process of what resin bonded bridges are. So with this, let's see the contents of the module. So we're going to briefly talk about the history of how resin bond bridges came into being, about the indications and contraindications, the various advantages and disadvantages, the step-by-step process, and the different types of resin bond bridges, how to maintain, what about the importance of recall, and also we're going to see a few review of literature. So as you can see on the screen here, can you recollect the different types of bridges that you know? So traditionally, we know that there are the traditional type of crown bridges. Apart from this, there is a subtype which is cantilever type of bridges, and there is also a specialized type which is implant supported bridges. So what about the fourth type that I've put up on the screen, which is what we're going to see today? Resin bonded bridges. So as you can see on the screen here, we have put up a definition of GPT, that is Glossary of Prosthodontic Terms, 10th edition. Let's first of all split this definition rather than having and by hearting this all together. So your resin bonded bridges are nothing but fixed partial dentures. Okay. They are minimally invasive fixed partial dentures, and they are luted to tooth structure. Primarily, it is the enamel, and through the enamel, how is it luted? It is through etching, and this is done through a micromechanical retention by which mechanism? Which is through your resin luting cement. So let's pull all of this together and see what the definition is. So it's a fixed partial denture that is luted to the tooth structures, primarily the enamel, which has been etched to provide micromechanical retention for resin luting agent. So resin bonding bridges are known by various names. They also can be called as resin retained bridges, adhesive bridges, bonded bridges. They also have different other names. So we'll see that in the upcoming slides. Talking about the history and development of resin bond bridges, we have to go back way back to the 1950s, wherein Bjorn first introduced acid etching. A few years later, Bowen developed BIS GMA composite resins, and finally this led to the development of resin bonded bridges and was introduced in the year 1973 by Rochette. So what about the indications and contraindications of resin bonded bridges? Let's begin with the indications. So primarily these are indicated in young adolescents with missing anterior teeth and short span bridges. We also use them in patients who are medically compromised because it requires fewer number of appointments. We sufficiently need enough enamel because without the enamel being present, it's difficult to achieve good amount of etching. So what about the contraindications? We do not use it in a long-term bridge. If there is insufficient vertical overlap, we do not use it. And also it is not used where there is not enough enamel present. We do not have adequate occlusal clearance. So in such conditions, we preferably avoid using resin bonded bridges. What about the advantages and disadvantages? To begin with, the advantages is that you have a minimal appointment time and it's a very conservative type of technique. We can now finish it in one or two sittings itself. However, the disadvantages is that you do not have that much of long-term success with resin mounted bridges. Sometimes you may have to go for other types of fixed partial dentures finally. And also we cannot change much of the pontic space. Okay, we have very limited options for it. So now let's see the classification. So based on type of retention, we have four types. This includes mechanical, micromechanical, chemical, and macromechanical. So let's see each of this one by one. The first one, which I said before, in 1973, it was introduced by Rochette. So it's a classical type of a mechanical type of retention. This was one of the first RBB to be developed. So it consists of the classic wing-like retainers with multiple flared perforations. It's used for providing mechanical retention for the resin cement. They can be used in both anterior and posterior teeth. And this is an example that you can see on the screen of how a Rochette bridge looks like. You can see the classic wings and how big these perforations are present. Now coming to the second type, it's also called as a Maryland bridge, and this is through a micromechanical retention. This was developed by Levatidis and Thompson, and it's called Maryland bridge because it was actually developed at the University of Maryland. So in this type of bridge, what we do is there is micromechanical retention, and this is achieved through electrolytic etching. So this electrolytic etching, they use 3.5% solution of nitric acid and a current of around 25 microamps per centimeter square for around 5 minutes. Calling this is immersed in 18% hydrochloric acid solution in an ultrasonic cleaner for around 10 minutes. So chemical etching and jelly etching also can provide similar results. So this electrolytic etching is through non-perforated base metal retainers, and they are bonded through resin cement. This is an example of how a Maryland bridge looks like. So remember that Maryland bridge, you have micromechanical retention. The advantages and disadvantages of Maryland bridge are as follows. It's got better retention than the perforated retainers. It is highly polished retainers, but it's a very technique sensitive type of a resin bonded bridge, and the retention is sometimes decreased. Coming to the third type, that is a macromechanical type, also called as Virginia bridge. So in Virginia bridge, as you've already guessed, it was actually developed at the University of Virginia by Moon and Hutchins. So this is a macromechanical type, and it utilizes a technique called as lost salt crystal technique. So I want you all to remember this particular diagram of a map of Virginia. So you can see that it is close to the Atlantic Ocean. So what is present in the sea? There is a lot of salt. Okay. So how to remember Virginia Bridge and lost salt technique? It is, if you remember, that Virginia is closer to the bridge. So this is a small technique that I want you all to remember, because most often I have found that students tend to confuse Maryland Bridge, which is micromechanical retention type, to the Virginia Bridge, which is macromechanical retention type, lost salt technique. Okay, so I want you all to remember this particular figure of map of Virginia, to remember that Virginia Bridge gets its macro retention through lost salt technique. So what are the steps in fabricating the Virginia Bridge? The die is first lubricated and sieved with the cubic salt, which is around 150 to 250 microns. It's sprinkled on the surface and leaving out the marshes. A resin panther is now constructed over the salt, allowing it to be incorporated into the resin, and then the salt is dissolved by placing the set pattern in an ultrasonic cleaner. So this will leave behind the voids, as you can see on the screen, which are reproduced in the casting, and this is what provides the retention of Virginia Bridge. Virginia Bridge's advantage is that the procedure can be done on any metal, and the bonding is superior compared to the Maryland Bridge. However, the limitation is that the thickness of the retainer has to be increased to allow for the retentive layer. Let's see A special type of RBP, which is cast mesh fixed partial denture. So in this type, what we actually do is, it is a mesh that is made out of nylon, as you can see on the screen. It's adapted to the lingual and the proximal surfaces of your abutment on. So this mesh gets incorporated with the following to provide the retention. Its disadvantage is that the adaptation is not so good, and the wax that flows actually might get interlocked into the undercuts. So you have to block out the undercuts. And the fourth and final type is your chemical or adhesive bridges. Now, these are the most common type that are available. Advantage is that it is a high bond strength, good fracture toughness, and a long-term clinical success. We can see some, studies which have actually proven it. And I'll show you all three examples of these adhesive bridges. First is a modified BIS GMA. So this actually contains a metal primer which bonds to your resin cement and the metal alloys. It can be used both in noble and base metal alloys. So an example of this type of modified bisgene cement is a Panavia. Now Panavia cement, it consists of 10 MDP as the primer. The next example is Superbond, was developed in Japan. And the primer that is present here is a 4-meta. Finally is a Rokatech system. So the Rokatech system, it consists of a coating unit, a microplasting sand, and this also contains abrasion particles that are actually deposited onto a coating of silicon alumina on the alloy surface. A silane coupling agent is then applied to bond the metal to the resin cement. So these are different types of the chemical adhesion. And finally, the most commonly used type of chemical uh, retention type of resin bond bridges, which are famously called as FRC posts or FRC bridges. There is fiber reinforced composite bridges. They are bridges that are reinforced by a bar of glass fibers over the composites which they are built, and they consist of a reinforcing constituent and a surrounding matrix. They can be of two types actually. So they are either pre-pregnated ones, or they can be impregnation required types. So before we move on to the step-by-step process of how resin-bonded bridges are made, I want you all to keep in mind these three things: the different phases that dictate the success of the fabrication of FBDs. Now, these include 1, the preparation of the abutment teeth; 2, the design of the restoration; and finally 3, the bonding protocol that we are going to follow. So now let's see principles of tooth preparation in the resin bonded bridges. The lingual axil reduction should follow the anatomic planes. The proximal preparation must extend labially, and this is dictated by aesthetics, how much we are going to extend it. It should encompass 180 degrees of the teeth, and we restrict usually only to supragingival margins. And the occlusal clearance of at least 0.5 mm is required. Resistance can be developed through proximal grooves and boxes, and vertical stops have to be provided. In the anterior teeth, this is through countersinks, and in the posterior teeth, it's through occlusal rests. So smooth preparation principles are different for your anterior teeth and the posterior teeth. To begin with, there are 4 steps in anterior teeth preparation. The first step is the cingulum preparation. So the cingulum preparation, what we do is, again, it's subdivided into 2 steps. Firstly, we have to use depth orientation grooves through round burr. Following this, around 0.5 mm of enamel is reduced through a wheel diamond burr. And preparation is terminated 1.5 to 2 mm from the incisal edge. The second step is the countersink or the cingulum rest preparation. So we use flat notches or countersinks which are prepared on the lingual surface using a flattened tapering diamond burr. So this provides enough resistance to the gingival displacement, and alternatively, cingulum rest also can be. Third step is a proximal preparation, and this is prepared in the 2 planes. So as I said before, it's dictated through the aesthetic. So labally and lingually, we use the rounded tapering diamond burr, and the groove is prepared with a flattened tapering fissure burr that is parallel to the incisal two-thirds of the labial surface. And finally, the proximal surface is extended in facially as well as the palatal surface. The fourth and final step is your lingual axial preparation. So it's continued from the proximal preparation adjacent to the edentulous space and continued around your cingulum and stopped just short of the contact of the proximal surface. And the surface is prepared with a rounded tapering diamond burr that is parallel to the path of placement. How about the posterior teeth? This is going to be different. Yes, there are some slight changes. Proximal and the lingual axial preparations are only aimed at lowering the height of contour and creating parallel surfaces. So the height of contour is actually lowered around 2 millimeter from the gingival margin. Proximal preparation adjacent to the edentulous space should extend beyond the facial line angle, and a 180-degree encirclement is achieved through a short, thin tapering diamond burr, and we achieve a knife edge finish line. A closer rest is prepared adjacent to the edentulous space, and its dimensions are it is 1.5 to 2 millimeter faciolingally and mesodistally around 1 to 1.5 millimeter in depth. The vertical walls have to be very distinct because this should prevent any lateral movement, and the preparation should progressively deepen as we move from the marginal ridge to the fossa. So how do we do the impressions for your resin bottle bridges? Preferably we use elastomeric impression material. If we can use a single step technique or a double mix, whatever is convenient. Coming to your bonding protocol. Now bonding is most important. So first of all, we have to prepare the tooth surface with pumice and water, achieve a clean tooth surface. And you etch your enamel and of course with your 37% phosphoric acid for 15 seconds and get a rinse it and dry it. Following this, we use a resin cement to load. A primer usually is applied to the fitting surface of your casting and a bonding agent is applied to the prepared surface of the enamel. The resin cement is next and placed on the internal surface of your retainer, and we use a finger pressure to insert the processes and maintain it for around 60 seconds. We can do tack curing to remove any amount of excess composite resin that is present, and finally allow it to go for a final setting. Occlusion is adjusted as and when required. So let's see the review of technique for the different steps that we have to follow. First of all, patient selection is very critical. Without a proper patient selection, it's not good to go for your resin bonded bridges. Occlusion has to be stable. So the tooth preparation would consist of creating a large lingual or your palatal bonding area with proximal wrap. So preferably there has to be a single path of insertion. We can give any retention, and this can be done through proximal grooves or slots that provide the resistance form. Occlusal, incisal or cingulum rests are also provided. An accurate elastomeric impression should be used, and a careful laboratory technique is necessary to ensure a well-fitting and aesthetic casting. And finally, we have to use appropriate resin luting agent that has to be bonded well to your tooth structure. Why is the maintenance and recalling of a resin bonded bridge important? Because if there is any small signs of debonding, if it's detected early, you can definitely prevent any unnecessary damage to the abutments. So periodontal health also has to be reviewed, and it has to be properly maintained. Otherwise, there is chances of accumulation of plaque. So why can there be failures? The failures can occur because of inappropriate patient selection, who have any parafunctional habits, if you do not prepare your tooth surface properly, and also because of bonding failures. So these are three primary reasons why resin bonded bridges can tend to fail. So now I want to share with you all a case report that I did. So this was a 22-year-old female patient. She had just undergone extraction of her 1-1, and she reported to me after 10 days, seeking immediate fixed processes. So what we did for her was the following steps. We did a FRC bridge, that is a fiber reinforced bridge, and I used the rebond here. So initially the tooth preparation is done, etching is achieved, followed by the bonding protocol, and we place the FRC mesh. So this nylon mesh is placed, and we develop the pontic. The pontic is then polished well, and you can see how we are able to develop the 1-1. And this is the final picture of the patient with the processes in place. Coming to the important part of the module, which is the review of literature. Now, any topic that you take up, right, it always has to be evidence-based. So let's see some important review of literature. So one major problems with resin bottle bridges, as I've been saying, is that there is a lack of long-term prospective data. However, there has been a few data available. For example, there is a 5-year survival rate of resin bottle bridges, close to around 87.7% success rate has been found. In a systematic review by Thoma et al., they found that there is a survival rate of around 86 to 94.4% after 5 years and around 82.9% after 10 years. In fact, Tizulas, they found that a cantilever design is more preferable than using two retainers. Okay, so what we conclude from what we have seen through in this module. Resin bottom bridges are minimally invasive, short appointments, and small time consuming procedures. They are definitely a viable solution, and they are very technique sensitive. So case selection is very important, and how you prepare and achieve the bonding protocol, how you prepare the tooth, everything is very important. So long-term results to replace the conventional uh, resin bonded bridges from your traditional bridges actually awaited, but definitely they are a good solution to providing a treatment for young adolescent patients in short span bridges, for example. So I hope at the end of this module, I have been able to inculcate these learning outcomes with you all. I hope you all understood the definition of what resin bottom bridges is, the basics of what resin bottom bridges are about, the different techniques, the different types, what Maryland bridges are, Virginia bridges are, what Rochette bridges are, and the step-by-step protocol for both anterior and posterior tooth preparations. And if I hope that you all have understood this, I want you all to also read from these following textbooks, which I recommend, which is Rosenstiel by Dr. Rangarajan and also one by Dr. Nalasamy. So these three books have got quite a good amount of literature. So I want you all to read that, and also some articles which I've mentioned in the slides. And finally, if you've understood this entire module, I want you all to answer this small quiz which I've put up on your screen. You can either use the Google form or you can even scan this. And I hope you all had an enjoyable time listening to this module. Thank you.